Excellent. All right, everybody, we're letting all the participants come in. We had a little bit of technical difficulty with starting the webinar. So we'll give it a few minutes. And for anybody who is on site in the Valley Center for Vision here at 490 Illinois Street, San Francisco, we are on the 7th floor and you can come on in. We are in the conference room enjoying this as a live view from here. But our speaker is remote today. So it looks like a few more participants are coming in. And I think we can get started now. So thank you, everybody, for being here. We are really excited to have Jamila Michener here. She is an associate professor of government and public policy at Cornell University. And she studies poverty, racism, and public policy with a particular focus on health and housing. She is the author of the award-winning book, Fragmented Democracy, Medicaid, Federalism, and Unequal Politics. She's the Associate Dean for Public Engagement at the Brooks School of Public Policy and is the co-director of the Cornell Center for Health Equity, co-director of the Politics of Race, Immigration, Class, and Ethnicity, or PRICE Research Initiative, and is board chair of the Cornell Prison Education Program. So I have been looking forward to this talk since we put it on the calendar. So Jamila, thank you so much for being here, and I'm looking forward to your presentation. For those of you attending who have questions, we will have time for question and answers at the end. Please put your questions in the Q&A box, and then we will have a moderated Q&A section at the end of the presentation. Thank you.
Thank you so much for that wonderful introduction. I'm excited to be here, and I appreciate you all inviting me and taking your time to come today. I know that, you know, Wednesday afternoon is a tough stretch. We're all trying to get over the hump of the week, and so it's wonderful to be able to come together like this. And some of my favorite audiences over the last several years, honestly, have been getting to talk to folks in medical grand rounds and in this kind of a context. So I'm excited, and I'm going to try to move swiftly. I have some slides I'm going to share about some research that might be useful or interesting for you all to hear, but I'm going to try to keep a pretty steady pace moving through that so that I can take some time at the end just for discussion and to hear from you all what you might think, what might resonate, what questions might emerge. So as you heard, I am a scholar who studies public policy, especially at the intersection of poverty and racial inequality. And so I think a lot about health policy in particular, and I think a lot about the policies that matter the most for people who are living in or near poverty and people who are economically and racially marginalized. So of course that brings Medicaid to the sort of top of the list of policies that I tend to focus on. And I've done a fair bit of work on Medicaid over the past decade plus. At the beginning, or just before the pandemic began, I had pitched a proposal to the Robert Wood Johnson Foundation, and with a collaborator of mine, Carolyn Barnes, who's a professor at Duke University. Carolyn had been doing work focused on WIC and SNAP, so nutritional assistance programs, and I had been for years at that point doing work focused on Medicaid. And Carolyn and I got together and were talking and realized, you know, these programs serve very much overlapping populations, but are experienced in very different ways. And we wanted to understand what the comparative strengths and weaknesses of these programs were, what the leverage might be for improving a program like Medicaid by drawing on maybe learnings from a program like WIC. And so that was like the original idea and impetus for the project. It was what we took to the Robert Wood Johnson Foundation, and they said, yes, we will fund this comparative project. And we proposed to them to do in-depth qualitative interviews that were 40 to 90 minutes with Medicaid, WIC, and SNAP beneficiaries in 3 key states, Kentucky, Pennsylvania, and North Carolina. And they approved the project in the at the very beginning, during that first week of March 2020. We had no idea that what was coming. The project wasn't about COVID because at the time that we were writing the proposal, that was not on our radar. But pretty soon, we realized that we were learning things that were relevant to the pandemic. It took us a while, obviously, because the pandemic was happening to get the interviews off the ground. And whereas we had initially planned on doing in-person interviews, we had to pivot and do remote interviews. But eventually we did get the project off the ground. And by that time, the pandemic was well underway and we were in the midst of a public health emergency. Because of that public health emergency, people were experiencing Medicaid in a very different way than they would have otherwise. And I realized that we were going to learn a lot, not just in relation to our original questions, but about the way that a policy like Medicaid operates during a public health emergency, and about the way that people who are on this program experience that. And I realized as we learned from the people that we interviewed about this, that there were insights we could take from their experiences to help us think more broadly about how programs like Medicaid are structured and how they might be better structured to help people who are looking for access to health care and resources, and who often struggle navigating these programs in order to get such access. And so what I'm going to show you today is some research from that project that really thinks about the experience or examines the experience of people who are on Medicaid during the pandemic and the implications thereof. So this is just a little bit of background on me. I do lots of work on Medicaid. I think about it through the lens of somebody who studies public policy. I'm a political scientist by training, so I don't just want to understand how Medicaid affects health outcomes, although that's something that's deeply important and that I care about. I really want to understand the experience of the program, what it means for people's social, civic, political, and other kinds of well-being. And so that just gives you a little bit of a sense of me. I won't spend very long here, but I always like to start here because I realized early on when I started to talk to different audiences about Medicaid that we all have different starting points in terms of how we understand what kind of program Medicaid is. And for many of us, we can focus on Medicaid as a kind of second tier of healthcare, right? Not getting as good reimbursements as Medicare or as private health insurance, and perhaps not getting the same level of access and care. And so I realize there's a subset of people that think, well, Medicaid is a net harm when it comes to health equity because it's a sub-tier of healthcare. And that is one way of understanding the program. And certainly I would prefer a world where Medicaid was reimbursed equitably or where everyone had access to the same kind of care. But in the context of the country that we are currently contending with, and in between now and whatever time that can be changed, Medicaid is actually a great boon for health equity relative to what would be happening to the folks that were on Medicaid otherwise, which for the most part would be that they wouldn't have access to health insurance. And so when we look at what the research record tells us about Medicaid, this slide is just a slither of it, and there's much, much more. We know that it's improving over the life course the health of children, not just their health, but their educational outcomes, their financial outcomes, their likelihood of using preventative care. In the long run, Medicaid even is connected to outcomes like likelihood of recidivism, of recidivating for people who are formerly incarcerated, whether you have Medicaid or not can affect that outcome, the likelihood of being evicted. And of all programs that are anti-poverty programs, Medicaid actually has the largest effect on child poverty. And so Medicaid is a program that is a boon for health equity. This is why understanding people's experiences with it and drawing on these experiences to try to understand how to strengthen the program and make it better is quite critical. And from my vantage point as a policy scholar and a scholar of political science, and a scholar trained in political science, I really think about policy design, administration, and then experiences. We design policies like Medicaid in a particular way. We administer them. And based on how we design and administer them at the legislative level and then at the agency level, people have a set of experiences. And those experiences are what determine how much access there really is, first of all, and how much that access translates into the actual benefits that we want and expect for health insurance to be able to produce in people's lives. Now, we know full well that health insurance and the healthcare system is only one part of what determines health outcomes in people's lives, especially the kinds of people who rely on Medicaid as their primary form of insurance, people who are living in near poverty, many people who are disproportionately likely to have chronic illnesses or be disabled and so forth. So this is a vulnerable population in the first instance, and there are all sorts of social determinants that can affect outcomes related to health in their lives. But we also know that some things that we have some immediate control over, like the design of and administration of policy, matters for their experiences and can therefore matter for the set of outcomes that we're interested in. So during the pandemic, we had a slew of policies that really changed the nature of the way that people were experiencing Medicaid. So the Family First Coronavirus Response Act is one example, and there are others. But these policies led to the infusion of resources into the Medicaid program for obvious reasons. Medicaid was going to be a key frontier on which to fight this pandemic, especially among the populations that were disproportionately affected. And so we saw investment in Medicaid at very high levels during the pandemic. And in exchange for the additional resources the states were getting, they had maintenance of effort requirements. And that meant a few things. It meant that they had to guarantee continuous coverage during the public health emergency. So whereas Medicaid is normally a program with a lot of churn, people are on and off and on and off because it's difficult to become eligible, to remain eligible, to do what you have to do to stay on that program. During the pandemic, all of that stopped. The federal government said to states, we're going to give you additional resources, but because we are in a public health emergency and for the duration of the time we are in that emergency, you will not kick people off of the program, right? So we saw continuous eligibility in a way we had not before across all different kinds of states. States also had other limitations. They couldn't increase premiums. They had to provide certain kinds of treatment without cost sharing. So no copays, no premiums. You might be like, well, premiums, copays, how much were Medicaid beneficiaries paying anyway? Well, not very much, but something. And research suggests that even small cost, $1, $2, $5, $20 a month, can be a barrier to care for people who are most economically marginalized. And states could do other things. They could expand eligibility. They could streamline enrollment processes, and so on and so forth. So states are equipped with all of these resources and now new tools for making it easier for people to get on Medicaid, stay on Medicaid, and while they're there, get the treatment they need. What does this translate into in terms of people's experiences is really what I'll share a little bit about with you. And to give you this information, what I did was I conducted a systematic qualitative study. That qualitative study was based on the principle of centering the voices of Medicaid beneficiaries. This is a Medicaid beneficiary that I actually interviewed before I began this project for a previous project that I work on, but I remind myself all the time of what it was that she said. I call her Angie. It's a pseudonym, as all and any of the names that I mention here will be. And she said to me, I interviewed her in Michigan. We were talking about her experiences with Medicaid. And she said, in anything, the poor are always who suffer most. And you know the saying, he who has the gold makes the rules. And the idea here is the people who are suffering the most are not the people who are making the rules, right? And it's most certainly true, is what Angie thought, that the folks who have the gold, who are making the rules, who have the advantages, who have the power, don't necessarily care in the same way as the folks who are most directly affected. They don't have people in their families, people close to them. They don't know anyone on Medicaid. And so they don't have the same stakes. They don't have the same understanding. And I draw on this insight and this logic to say, if we truly want to be able to improve our health system, we have to draw on the voices and the experiences and the knowledge of the people who have the most at stake in that system to understand the various aspects of it better and to think about what it looks like to improve. But that is the exact opposite of what tends to happen. in the study that I'm going to share with you now, one of the questions that we ask people in our interview protocol is, do you think you can share, do you think you have any ability to influence the processes that affect you in this program, in Medicaid? And again, to lots of the other questions that we have, people's answers are quite heterogeneous. For this question, the answer is generally homogeneous. There's very little variation, right? So people essentially say, no, I don't have a voice. I don't have any influence. Our voice don't really get heard. And you might think, like, well, this is because Medicaid is a complex program and people who might be experiencing it don't necessarily know about it. They don't necessarily know how to fix it. It's complicated and we need experts for this, right? And while to some extent, some of that is true, to a great extent, there's actually a lot that you learn about anything, any program, any institution by being a part of it and by using it and by recognizing how pivotal it is for your well-being. So there's a lot that Medicaid beneficiaries know that we can really, truly never know without talking to them to understand it better. So that was the goal of this project. I'm going to share with you today some of the qualitative data from the research that we did in Kentucky. We also did hundreds of interviews in Pennsylvania and hundreds more in North Carolina. We are in the process of coding that data. We have millions of pages of qualitative transcripts, and so it takes a long time. We started our coding in Kentucky, and that's where we've gotten furthest along, so that's where I'm sharing with you from today. Our social policy project in Kentucky, like I mentioned, was qualitative. We interviewed people for anywhere between 20 and 70 minutes, although the average interview was about 50 minutes. We talked to people who had Medicaid, WIC, and SNAP. I'll focus on Medicaid today. We talked to beneficiaries primarily, but we also talked to staff who worked at Medicaid agencies. We wanted to try to triangulate perspectives that way. And we asked people about their experiences with these programs. In Kentucky, we did the interviews between December of 2021 and September of 2022. And there's some basic data about our participants. In Kentucky, we interviewed 148 people, and this tells you a little bit about who they were. On average, they were around 40 years old, but we had quite a range in age. Most of the people that we interviewed were beneficiaries, were Medicaid beneficiaries. Most were women. A disproportionate share were white. This is Kentucky, but we still had 22% of our interviewees who identified as Black and about 6% who identified as Latino. So we have some variation there in experiences across categories of race and ethnicity. The qualitative approach here, I won't spend very long on this, but the qualitative approach here is really motivated by a goal of description. We want to understand what people are experiencing. So you won't hear me make strong causal claims. I do lots of quantitative research, and in that context, I leverage different kinds of quantitative data to be able to make strong claims about cause and effect. That's not what we're doing here. We want to understand what people are going through, and in particular, what are people experiencing during the pandemic as they experience these programs that have now changed in significant ways, and what might the implications of that be, right? And so when you want to understand how some people are experiencing something, when the goal is description, qualitative research is the best approach. It helps you to understand what you don't know, and even what you don't know, what you never even would have thought about, unless and until you had the people who were experiencing this thing right there in front of you. So I talk about policy experiences, and I break this down in a number of different ways. Some of this is experiences people have with eligibility. Many people became eligible or remained eligible during the pandemic when they wouldn't otherwise have. They realized that, and that shaped the nature of their experiences. Access and utilization. Just because you're eligible and enrolled in Medicaid, it doesn't mean you're going to fully be able to access the range of benefits that are available or utilize them. And quality, what's the nature of people's experiences, and how might that affect the ways that they operate in relation to the healthcare system and beyond. So if we think about experiences during the public health emergency with gaining coverage, there are a couple examples here, and I'm not going to sort of read through each one, but what I will say is that many, many people told us things like this. They gained coverage that when they wouldn't have had it before, and it really affected their behavior. So for example, one of the things that people told us quite commonly there were people who had been wanting to, hoping to, trying to get on Medicaid for years, but couldn't. And when they were able to get on Medicaid during the pandemic, they knew it was because of the pandemic. They assumed that it was short term, that at some point in a year, in 2 years, whenever the pandemic was over, they would be kicked off. And they tried to pursue as much care as they could, as quickly as possible before they lost those benefits. So there's a woman who talked about how she depleted her retirement. She only had $3,000 left to live on. She had had all of these terrible things happen to her. She was, she had PTSD. She was a victim of sexual assault. She'd never been able to get on Medicaid before. So when she gets on Medicaid, what does she do? She says, I had 3 surgeries in 5 months and I've been undergoing therapy. She immediately tries to get all the care that she needs before her access is potentially threatened. She says, I've only been able to access Medicaid since I lost my job when COVID started. So knowing that you can only access this program under very unique circumstances, what do? You try to get all the care that you possibly can. Similarly, a woman says, I got on Medicaid during COVID and had the surgery, right? This was a woman who told me about a surgery she had needed for years. Her health was deteriorating. She was soon going to lose her ability to work, given her deteriorating health, but she could not get Medicaid. When she was able to get Medicaid during COVID because of the pandemic, she immediately got the surgery she needed. She had amazing results, she says, and her synopsis was, as messed up as our healthcare system is, Medicaid probably saved my life. So people are gaining coverage and they are getting care. On the one hand, that's good. On the other hand, it's good, period. But it's also worth thinking about, what does that mean for the stress that was placed on the system, for our ability to respond? And these are people that I'm interviewing, remember, past the point that's like the absolute height of the pandemic. So maybe if these folks were trying to schedule their surgeries in 2020, late 2020, it wouldn't have been able to happen. But by the time they're in, 2021, mid to late 2021, they're still able to receive Medicaid, and they are able to get care, because things are starting to be possible again in ways that they weren't early in the pandemic. And so we just see people gaining coverage and getting care to a different extent that was possible before, to the point that many people that we interviewed would call Medicaid COVID Medicaid or pandemic Medicaid. It was almost a different brand of Medicaid that people were understanding this as. So they would say things like, it was the Medicaid for COVID, right? Because the Medicaid for COVID is different than the regular Medicaid. Why? I didn't send any proof of income or anything in. The doctor's office did everything, and their caseworkers did. And the next thing I know, I have this Medicaid card. But it was strictly just a Medicaid card for the pandemic. And so doctors' offices are playing a key role here, and medical institutions are playing a key role here. They realize that people now have access in a way they haven't before, and they're connecting them to those benefits in ways they may not have been able to otherwise. And it's easier for people because enrollment is streamlined, because the administrative burden associated with the program is lightened. It's easier for caseworkers and for healthcare institutions to enroll people. Although, of course, I'm sure those caseworkers and healthcare institutions are experiencing a lot of stress in the context of the pandemic. But one potential silver lining is that they have more leverage for being able to get more people coverage. And people get coverage, it's easier to get coverage, and it's less costly. What one person told me, I've noticed that where I had like $2 and $3 copays or $5 copays before, I don't have any now, but I never understood why I had them before, right? People always struggled with copays, like, wait a minute, I'm on this program because I have low income, but you're making me pay things. And that never really made sense to many people, but it goes away during the pandemic. And they notice, and it's meaningful. Many people talk to us about copays. People also talk about remote options. It's just easier to do Medicaid over the phone. You still have to wait. It doesn't make everything perfect, but it's easier than if you go into the office. And the pandemic opened up remote options in a way that hadn't been there before. And people say things like, that makes it easy, so you don't just have to you don't have to just get on the phone for a while. Or you just have to get on the phone for a while. So that was a part that people talked about quite a bit. It's worth saying that people didn't only share positive experiences. They also shared some of the challenges that persisted even during the public health emergency, even with the additional influx of resources. Part of this was because capacity issues. The pandemic really stretched capacity for obvious reasons. And part of it is because even with more resources and with more support, some of the pre-existing challenges and disjunctures in the healthcare system do not just disappear. So this is a woman, for example, that talks about her daughter having to have a COVID test because she got sick and the school required her to have one. My kid's school no longer does this, but they're all through last year. If your kid had so much as a sniffle, you couldn't bring them back to school without a PCR test, and an over-the-counter test would not do. And so you have to go to the doctor, you have to go somewhere. She says, so their family doctor couldn't get her daughter in, and she takes her to a kind of a local urgent care place. And everything seems fine, but a month goes by and they get a bill for $900, and there's a glitch in the system on Medicaid's side. It ends up being a real battle and challenge. Eventually, she gets it taken care of, but has to make lots of phone calls. And in the course of this interview, talks about being reluctant next time to take her daughter in for care if it means that she's going to have to fight a prolonged battle after the fact to stop herself from facing exorbitant medical bills. And so there were still problems. One of the good things about this project is that we were working directly with the Kentucky state government, who helped to facilitate our recruitment of interviewees. And we would meet with them regularly and share what we were learning. And this was a glitch that numerous beneficiaries were telling us about. And so we told them about it. And they were able to look into it and resolve it before more people continued to have these challenges. Another core challenge that persists throughout the pandemic, because it's not one that can be solved quickly or by an immediate infusion of resources, is challenges with access. People talk about the lack of providers. In this case, the person is talking about dental providers, but people talk about lack of providers more broadly in rural areas, even in urban areas, but especially in rural areas. Just how hard it is to find a provider, how hard it is to find people who will accept Medicaid. And they know why. You know, we sometimes think, ooh, Medicaid reimbursement, that's a policy wonkish issue. People on Medicaid know this person says, and if it's depending on what they pay, what they cover, then that needs to be looked into. This is a recognition like, well, you know, you get paid less to take Medicaid patients, and that has implications for who accepts Medicaid, and it has implications for our ability to get the care we need. And so even if you're enrolled, and even if you have that, as many people call it, Medicaid card, and you should be able to go to the doctor, if there isn't a provider within a 30-mile radius, a 50-mile radius, and so forth, because we don't have a structure of providers that allows for that, then it is a problem. And this wasn't a problem that the pandemic solved. And then, of course, people have experiences with simply not knowing about benefits, even benefits that they do have access to. And the pandemic doesn't necessarily solve that, right? The public health emergency doesn't directly address this, not without significant outreach. This woman talks about having to take her son to Louisville every 6 months because of his need to see a neurologist there. And of course, Medicaid has a transportation benefit, but based on what she says here, she knows nothing about that. She says, I did hear from someone that there was some kind of program you could apply for assistance with gas money. And I don't know if that's true, but I've never, to my knowledge, received anything from them saying, oh, hey, you can do this for your trip to Louisville. And so there are resources embedded in Medicaid that people simply continue not to know about, even during the public health emergency when new people are coming into the program and significant efforts are being made at outreach. And then finally, there's this issue of the nature and quality of people's experiences, right? Many people would say things like this. At the end of the interview, we would ask people, well, what is there anything you think the Medicaid could do to be improved? Anything you think could improve Medicaid? Many people say the most common response is, we wish there were more providers. People just want more providers. And they want to feel like they can have access to the best providers, right? We wish we could go see a doctor in whatever neighborhood we want to, not just the lowest income neighborhoods. and we wish we could see the doctors that we think are the highest quality. The sense that they're being cut off from access is a really strong one, and that comes up quite frequently. Then people also talk about how they're treated. This is primarily in the context of Medicaid agencies, like those bureaucracies, sometimes in the context of healthcare institutions as well, although less commonly. Some people say things like, I don't think that my doctor knows that I have Medicaid because they don't treat me any different. And so there's an expectation that if someone knows you have Medicaid, they're going to treat you differently. And that expectation comes from experience. And so sometimes beneficiaries would say, oh yeah, the nurse definitely knew I was a Medicaid patient. That's why they kept me waiting so long. Now that might not be why they kept you waiting so long, but it's your understanding of why, which then of course is going to affect that interaction and the way that you think about and relate to that healthcare institution. But this is an example of someone talking about experience they have when they're engaging with the Medicaid bureaucracy, with that agency. But I think it can apply to all institutions that are significantly interacting with Medicaid beneficiary. What does this person think is needed to make Medicaid a better program to experience? Increase awareness about being empathetic and compassionate to people seeking resources. I felt like I was judged. And so, yeah, that would be my suggestion, because I don't. I think people need to be treated or should be treated with respect. I feel we're all equal and connected, and treat people like I want to be treated. People shouldn't be in a customer service oriented role if they can. And this was a common refrain that we heard people say again and again. I want to be treated with dignity. I want to be treated the same as everyone else. I don't want to feel like I'm receiving some different tier of treatment because I rely on Medicaid. So I want to wrap up here so we have time for Q&A. Excuse me. I am going to take a sip of water. I'm from New York City, and I'm a fast talker. And my mother always used to say that fast talking catches up with you. So there you go. You experienced the fast talking catching up with me. So key takeaways here. This descriptive evidence that I offer of experiences with policy that are a function of how policy is designed and how it's administered, they can both inform research, like the research I'm doing, that's qualitative. They can inform quantitative research, help us to think about and have better hypotheses. All of that is very scholarly and intellectual. It's important, but most importantly, I think, is that this kind of evidence can inform policymakers, practitioners, administrators, people, perhaps like some of yourself, who are on the ground, who are having interactions with populations of people who are on Medicaid, especially during a time of change, especially during a time that is pivotal for people. And I think that there's value in Medicaid beneficiaries, their voices guiding our processes and our understandings of the institutions that we operate in. I think this can help to build power among beneficiaries who, of course, have the most at stake. And so should, I think, as a kind of normative principle, have some say and influence over the processes that are affecting them and their communities. But again, when we talk to people and we ask them whether they have an influence, the refrain is clear. This is Janine, a 60-year-old Black woman from Kentucky. When I asked her this, said to me, no, we don't have a say, but I wish we did. I think we should have a say in it. I think we should matter. We still got to eat. We still got to eat. What does that mean? We're the ones who have the most at stake. We're the ones whose needs are not going to be met. And so sometimes people will say, well, I'm sure Medicaid beneficiaries don't want us asking them about every little thing. They're busy living their lives, and their hard lives at that. And it may be true that we have to think carefully about what kinds of expectations and burdens we put on folks in these positions and in this population. But it certainly isn't true that people don't want to have voice and influence, because we ask them and they say they do. And many people, in fact, at the beginning of the interview will say things like, I can't believe you want to talk to us. I can't believe you want to talk to Medicaid beneficiaries. Nobody ever asks us what we think. I've had people that have gotten tearful just talking about how useful it was to talk through their experiences and to feel like someone cared. So this project is a part of a larger effort to really center the experiences of Medicaid beneficiaries. But under that larger umbrella, we get lots of nuanced, granular, practically valuable information about how that program operates and how we might think about contributing to its improvement. All right, I'm going to stop there. And I'm gonna also stop sharing my screen just in case it's easier for you all to see me. And happy to jump into Q&A.
Yes, thank you so much. And we already have questions coming into the Q&A. The first one comes from Rita Hamad, who is a social epidemiologist. And so I know, so she says, thank you so much for speaking today. What a fantastic talk. I'm part of a team at UC doing similar qualitative research, trying to understand WIC and EITC recipients' experiences with their programs. When we ask them about how the experience could be better, many focus on what they as individuals could do differently and often don't think to make suggestions about the system. Have you noticed this pattern?
Oh, this is great. First of all, lovely to meet you, Rita. Thanks for that wonderful question. And I'm super curious to learn more about your research because, we all are also talking to WIC beneficiaries. We aren't asking people about EITC, but I imagine these are similar populations. The short answer is yes. It's very much the inclination of Medicaid beneficiaries and other people, more generally, in part because I think a lot of this is baked into our kind of social and political culture in the US, to think individually or on an individual level, even about systems and systemic problems. We do structure the interview protocol in a way to encourage people to think about systems. And we start the protocol very much asking people about their individual experiences. What's it been like being on during the pandemic? And gosh, that we didn't anticipate how difficult starting with that question. We added that question after the fact because we were like, well, we're in the middle of a pandemic and we have to acknowledge that when we're talking to people. And we asked them, what's it been like? And people really talked about individual challenges in their lives, and sometimes very painful to listen to what people were going through. But as we built through the protocol, we asked more and more questions about the systems and the processes and the structures, and we flagged that for people. And we would say, now we want to think about Medicaid and what's going on with that program and what's going on with that policy. And we also framed the intro for people in terms of wanting to understand the program and the policy and how to fix it. And towards the end, when we asked people that question about what they thought could be improved, we asked it also in the context of asking people, like, what role do you think the government has to play in the way that you experience Medicaid? What role do you think health systems have to play? We really prime people to think in terms of systems. And of course, there are contexts, in an experimental context, you may or may not want to prime people in this way. But in this context, we really want people to think about systems and to tell us what those thoughts are. Now, some people just don't have any thoughts. They just can't get out of that individual framing. And so we'd say, can you think of anything that could make Medicaid a better program? And people would say, well, not really. Or they'd say, I wish that the benefits were more. So when we ask people about SNAP and WIC, I really wish the benefits were more. But they wouldn't even frame it in terms of the government or a system, just in terms of the benefits, which is really in reference to the thing that's most relevant to them as individuals. And so, yes, that is definitely a pattern. And it's a challenge, right? It speaks to, I think, some of the changes in our ways of understanding, our ways of interpreting the world that are going to be necessary on a wide scale if we're going to see changes to these kinds of programs.
We have a second question from Janet Kaufman, who's also on our faculty here at IHPS, who says, can you say more about the strategies you use to recruit Medicaid beneficiaries to participate in your study?
Absolutely. This is one of my favorite questions. I think this is one of the most tricky and difficult parts of a project like ours. And while I shared about the 148 interviews that we did in Kentucky, across our different sites, we did over 500 interviews. And if that were a survey, you'd be like, that's a low end. But for a qualitative study, that's a ton of interviews. It's a ton of work. I will say that we had quite a bit of support and capacity thanks to the Robert Wood Johnson Foundation and their generous funding. So we had two project managers, each at different sites. One of the reasons why it was a year between the time that we got the funding from the Robert Wood Johnson Foundation and the time that we conducted our first interview in Kentucky is because we took about 6.5 months, almost 7, just to build relationships, just to I had one organization I had some familiarity with in Kentucky, Kentucky Voices for Health, a big healthcare advocacy organization. Started with that one contact and said, we want to build relationships that are going to facilitate us doing this research. And across a series of meetings, we convinced the Cabinet of Health and Family Services in Kentucky to work with us. So we had the folks that were spearheading Medicaid, WIC, and SNAP in that state directly involved in the study. And we gave them a bit of leverage over how the study proceeded. So, for example, we allowed them to ask to ask questions. So we said, are there questions you want to add to the protocol? And they did ask questions. Or are there things about the protocol you want to change? And they did that. So we had a really robust partnership with state government, folks in state government, and advocacy organizations. And that took time to build. But once we built it, it very much facilitated recruitment. So our advocacy organizations recruited among their numbers, but they also connected us to community organizations that helped with the recruitment. And then our state partners helped with recruitment as well. So the Department of Child and Family Services, for example, consistently posted ads that we had on their Facebook and other social media pages. We sent them flyers and postcards that they put in their offices physically. And we checked in with them monthly as we were progressing. If we had, at the beginning of the project, we had a whole slew of people sign up. We started out strong. And we realized that was because we started interviewing in December. We were offering incentives. We were offering people $50. Well, in Kentucky, 30. It was different amounts in different states. That's because we started in Kentucky and 30 was the original amount that we wanted to offer people. And our partners in Kentucky thought that was great. When we moved to Pennsylvania, our partners said, we don't think 30 is enough. We don't think that's acknowledging people's time in a sufficient way. So we upped the amount in Pennsylvania to 50. But the point is, we were offering people incentives. And so because those original interviews were happening during the holidays, people would say, can we do this interview before Christmas? I need the money to buy my kids gifts, which is super sad. You know, $30 was the difference between being able to have a gift for their child or not. So we had a huge number of people in that first month prior to Christmas. And then things really slowed down and we reached back out to our partners and said, okay, things have really slowed down. And we had an ongoing recruitment effort and conversation. It was not a one-time thing. It was a lot of work.
I can believe it, having tried to recruit workers for interview studies over a lot of the pandemic period. Not easy to do, even with incentives. Kudos to you with the community partnerships really helping to do that. We have a question from an anonymous attendee that says, thank you for sharing your important research. You describe a massive qualitative database. Could you talk about questions you'll be using those data to answer in the future? And if we have time, which I think we probably do, any insights you've gained about large-scale qualitative research that we could learn from?
Absolutely. These are the best questions, can I just tell you all? Sometimes people ask me questions and I'm like, oh, that's the boring part. Ask me something else. And you are asking the questions where I'm like, yes, let's talk about this. So thank you for asking wonderful questions. You know, it is massive. I don't think I realized how massive it was. You know, I have done qualitative research for a long time. And for example, my book that I published that was on Medicaid was based on 60 qualitative interviews and a lot of quantitative data as well. But those 60 qualitative interviews were rich and amazing and more than enough to write that book, right? And so going into this project, I knew that the scale was larger. And in part, we did that because we were like, well, we're trying to compare multiple programs. And so we want a wider range of people. And so let's prepare to answer, to interview more people. But I still don't think I had a sense of quite what an undertaking it was, to be frank. In terms of the kinds of work that lies ahead of us, so we just got our first paper out that compares experiences with Medicaid, WIC, and SNAP. And so we're going to continue to do some of that comparative work. We, for example, found that people reported much more positive experiences with WIC than they did with Medicaid and SNAP. even during the pandemic. And we wanted to kind of we've been working to try to wrap our mind around this. In many ways, at least in my field in political science and to a lesser extent in sociology, people have been critical of WIC as a paternalistic program. You have to meet with a nutritionist and a dietitian, and they're just in your life in a deep kind of way that we might think is condescending and paternalistic. We found that people were telling us that that was supportive, that it helped to build relationship, and that relationship for many people, not everybody, was what they most desperately needed during their time of acute struggle. And so we're really going to draw on that. We're going to continue doing this work around the comparing the experiences of people who very recently got Medicaid in the context of the pandemic to people who we interviewed. There are many people who we interviewed who had a longer term experience with the program and who talked us through the stages. Well, this is what it was like a couple of years ago, and then the pandemic happened, and man, it was really different. And in Kentucky, toward the end of our interviews, Kentucky had the pandemic hadn't ended as far as Medicaid, but they'd started to transition out of some of the changes they made to the agency. Like, they were pulling back on some of the remote options, and the SNAP benefits had decreased again and things like that. And so people sort of had a before, during, after perspective that was super rich. And you don't normally get those kinds of clear breaks in this sort of research. So we're gonna draw on that. We noticed, particularly in Kentucky, but also in Pennsylvania and also in North Carolina, these are 3 states that have substantial rural populations. Because our interviews were so wide-ranging and because our recruitment was so intensive, we got a fair number of people in each state that are from rural areas. That's unusual for a qualitative study where it's easier to recruit in urban areas, honestly. And so we have a lot of people from rural areas, urban areas, and there's some place-based things that we want to try to understand about differences in people's experiences that we haven't quite had the qualitative leverage necessary to do before. We're going to be able to dig into that in a big way. And the last thing I'll say is our ultimate plan is to try to de-identify this data in a systematic way so that we can make it available to others. And some of this is going to depend on what we negotiate with the funder and depend on how much we can de-identify and depend on whether we didn't initially ask beneficiaries if we could share the data outside of the context of the project because we didn't think of it. But now we realize that we have this huge data source that we probably won't be able to leverage as well as it should be leveraged exclusively on our own. So we're looking to share the data, and that's going to take some nuance because we have to do it ethically. But that's a goal because we want other researchers who care about these kinds of things to be able to benefit from the knowledge as well. And, millions of pages of transcripts are a lot. And we have, we have some possibilities there. As far as what I would say about large scale qualitative research, so this might be an odd place to start, but the first thing I would say is qualitative research doesn't always need to be large scale. And I would even say it doesn't even often need to be large scale. And so what's interesting is the previous work that I've done on Medicaid based on 60 in-depth qualitative interviews, a lot of those insights are repeated in this in this data. Not all of them. We got new ones for sure. But the core questions that I asked the first time around when I did those 60 interviews, really this replicated them, which says that we can learn a lot by doing less, right? And that when you reach that point of saturation relative to your theoretical interest or your research question, it really is an effective place to stop, right? More isn't always better. And I think that's important because as somebody who's multi-method, of course, in a quantitative context, you want more people answering your survey. You want more, because you're trying to generalize, and that has a certain, it lends a certain legitimacy to the research, often for good empirical reasons. But we can absorb that when we transfer to the qualitative context, and sometimes in ways that are inappropriate, and make us do more than we really have to learn about the core things. So large-scale qual research, absolutely important. I don't want to give the impression that it's necessary. But I think it's particularly valuable when you have many different factors at play. So like I said, we have people across multiple programs. We want to understand what people are experiencing in urban and rural areas. We really wanted to understand differences across racial groups. That's quite a lot of, those are many axes of variation. And while we're not trying to generalize, we want to have a wide enough range of experiences that we're tapping into the axes in a way that has some depth. And so that's the logic for doing more. It's function of what you want to know, of what kinds of research questions you have, and of the scope of those questions. And the scope of our questions in this case warranted, I think, doing more interviews. But it's expensive and it is hard. If we didn't have two project managers who were managing the project, there's no way we could have done it. They managed the logistics, right? We all did the interviews. I would also say I recruited an interview team, and this is the first time I've done this in this project, and then I'm going to stop, I promise. But we were very intentional about trying to recruit an interview team that included people who had experiences with the program. So, for example, we had 6 people doing interviews in Kentucky. 4 of the 6 were people who had been on women who had been on Medicaid, WIC, and SNAP, right? The 5th was myself. I sort of count because I grew up on these programs, and nearly everyone in my family is still on them. I managed my mom's Medicaid case for the last few years of her life. She's no longer with us, but so that's 5 out of the 6 people on the project who had really in-depth experiences with the programs. We tried to replicate that across the board, and it changed the nature of the interviews for sure. And that's something I learned in this project that I don't know that I would have been able to implement that on a smaller scale. And I don't think it's reasonable to necessarily expect people to. And so those are some top lines, but a few people have told us we probably need to write a paper just on the qualitative aspects of this, like the nuts and bolts of doing it. And so we may work on that.
Great. We have a few more questions, and so I'm going to merge a couple of questions together, and because they're kind of related. Janet Kaufman again, and then Lurit Beppo. And their general questions were around kind of a combination of policy changes or policy needs regarding maintaining any pandemic provisions. And kind of related to that, how do you frame things like a Medicaid expansion in a way that would persuade politicians to actually support it? Does your research help inform that? And of course, you're a political scientist.
Yeah.
And then also, are there components of Medicaid policy as we're moving forward past the public health emergency that really should be prioritized to try to maintain?
Oh, these are all the fun questions. Okay, I'll try to be quick because there are several of them. So absolutely, there are components that we should hold on to going forward. I think if there's something beautiful that the public health emergency gave us is the ability to say, look, we change things dramatically, and here's what happens when we change things dramatically, and here are some things we want to hold on to. So for example, I think, of course, we want to hold on to the remote options and the telehealth pieces, but we also learned quite a few people in the study told us about the frustrations with that, right? So people have a really difficult time with remote options and with telehealth in rural areas, right? And we might think, everybody has a cell phone. Not everybody has a cell phone that's reliable and works. Many people, if you can't see well, if you're older and you're not comfortable with technology, navigating these things on a cell phone is burdensome. And so older people and people in rural areas really complained about the shifts to doing things remotely and relying on technology. That's something that we got really deep qualitative information about that we can present to policymakers and say, look, it's not to say that we're not going to expand in these areas, but we have to be careful about how we expand. Similarly, continuous coverage. Look, the number one thing people told us when we said, well, what's most different about Medicaid now that it's the pandemic? And people just say, it's easier to stay on. They don't make me jump through fire burning hoops. Why couldn't they do this the whole time? People are very savvy. They're like, oh, this is a choice? You could have made it easy for me the whole time, and you chose to make it hard. Is essentially what state governments are doing. And so we can choose to make it easy. And that's information that we have been presenting. I've been actively presenting state policymakers with that kind of information. And hearing it in people's own words makes a difference. Now, the politics of that is complicated. For example, the politics of continuous eligibility or enrollment, that's more expensive. In many states, like we kind of want to make it hard for people so that we can wean folks off of this program, or we can filter out the people who don't really need it. And that saves us money, right? And so to the extent that there's a financial and political prerogative, small government or what have you, to minimize a program like Medicaid, you don't want continuous enrollment. And sometimes there's no way around those political barriers, except for the people who want it to have more power and to win, right? And Medicaid beneficiaries are among those people. And this is why I think research that centers them and that builds their power and that reinforces the importance of their voice is important, because they're the precise constituencies that we need involved in these battles if we're going to get things to be different in a way that's supportive of health equity. But I will say, on maybe a less confrontational, I'm not the kind of person that's like, if everyone just knew the science and saw the research, they would do the best evidence-based thing that's good for the most people. Sometimes yes, oftentimes no. That's not the way politics works, right? But I also do think there are opportunities to work in ways that are bipartisan, and it helps to have this kind of information. So in Kentucky, for example, the state advocates that I worked with invited me in December to an event that included some legislators to present some of the data from the study to them. They asked me to focus on the benefits cliff, right? The fact that people were running up against income limits and that was making it difficult for them to remain on the program. And that stopped during the pandemic. And many people talked about how significant and important that was for them. Nobody says the benefits cliff, but a lot of people talk about income limits and how income limits have been a consistent barrier to them being able to access healthcare. Many of them say things like, I work really hard, but I had to make my teenage daughter stop working her summer job because that income put us like $200 over the limit, and that's not worth not having healthcare. Or I had to cut back on my hours. I had to tell my boss I couldn't take that raise. And that's a message that has bipartisan resonance. I mean, we had some Republicans from the Kentucky Assembly in the audience who are all about hard work and personal responsibility. And to hear people say, I want to work more, I want to work more hours, I want my kid to work more, we want to take responsibility, but you've set this program up in a way that disincentivizes us. That was a significant moment. Actually, one of the Republican legislators said, hearing this and hearing it from people, hardworking Kentuckians, makes a difference, and we're going to have to see how we can address this problem. And so there's a long way between that and change, but I do think bringing these narratives to policymakers, especially depending on the nature of the narrative, can be an effective pathway.
Great. Well, thank you so much. We are out of time, so I'm sorry to the last couple of questions out there that we don't have time to get to them. But there's so much information here. I am feeling like my brain is kind of full, and I really appreciate it. A lot of food for thought for my own work, and I'm sure for many of our colleagues. And thank you for what you are doing in sharing this information in policy circles, because that, in the end, I hope will have a big impact for people living in the states where you've done this work and nationally. So thank you for being with us this month. And for those of you who are regular attendees of our monthly health policy grand rounds, take a look at our website to see our schedule for the rest of the spring. We have a great roster of speakers. Some are going to be on site with a hybrid viewing option, and some will be remote only, and that's all specified on our website. So thank you very much, Jamila. It was great to meet you virtually.
Yeah, this was fun. Thank you all for your wonderful questions and your very close engagement. Thanks a lot.
Thank you. Bye-bye.
Bye.